Medic 43, District 1, Engine 51, response, cardiac arrest.
Hello, everybody. Welcome again to another edition of the MCHD Paramedic Podcast. This is Dr. Casey Patrick, and today we're going to discuss cardiac arrest. If there's something that we cannot discuss enough in EMS, it's out-of-hospital cardiac arrest. It's the most impactful call that we can possibly run, and we've learned some lessons here at MCHD recently, and I wanted to bring on some regional partners to discuss the Resuscitation Academy. And we were a part of a Resuscitation Academy event down in Lake Jackson several weeks ago, and we're able to bring back some really excellent learning points and protocol changes for our crews. And so we have some guests from another hospital district, not MCHD today. We have Parker County Hospital District up in North Texas. And joining us is Justin Northeim and Skipper Bertrand, a couple of the medical directors, and Jeff McNew, one of the supervisors there. And I'll let y'all introduce yourselves and tell the listeners what you do there every day, a little bit about PCHD. It's hard to say PCHD and not say MCHD. And then we'll roll into what is the Resuscitation Academy and some of the learning points that MCHD brought home from this really awesome event. So take it away, guys.
Yeah, so my name is Jeff McNew. I'm one of the supervisors here. We have 3 supervisors in the county on duty at all times. We carry blood as well as EPOC for labs and respond to kind of the higher priority calls. And when the doctors are here, we get to respond with them. So
I'm Dr. North. I'm one of the medical directors here. Been involved with EMS since I was probably 15 years old, so great passion. I'm also a ER boarded doc with the Baylor and IES system up here. And so I'm very happy to join. We've been following MCHD Podcast for quite a while, and we thought it'd be really neat to kind of see what each other's doing and kind of learn from each other. So glad to interact with Casey today.
I'm Skipper Bertrand, one of the medical directors, also here with Dr. Northeim. And we spend about 8 days a month out here with the crews, running calls and doing some education. Some days we are lucky enough to get out here together on the same day and do this, and it's a lot of fun for us. I've been involved in EMS since I started this career 23 years ago, and I never cease to be amazed at the kind of changes we can make here at the patient level so quickly through an EMS program. So it's been really rewarding.
Awesome, y'all. Well, thanks for joining today. Let's hone in on the Resuscitation Academy because y'all have been absolute leaders and pushed this forward in your service and your services. And just for the listeners out there that don't know what the Resuscitation Academy is, what is it? Why should everyone care? Why should this be something that we're looking towards? Give the listeners a little bit of background into the RA and what it is and what y'all do.
Well, I think Resuscitation Academy is really based out of Seattle and King County area. And many, many, many years ago, there were pioneers in cardiac arrest. And I think the way that we used to do things on the box with hurry, get airway, hurry, get an IV, and do compressions last, we all realized that wasn't working. And so thank goodness for Seattle and King County for really starting to hone in on things that are important. And they have a very much EMT basic-based system there. I believe it's like 90% last time we checked. They have very few paramedics, and they really do cardiac arrest care better than anyone in the world. And so I was invited to go to the Resuscitation Academy in 2019, which is probably 20 years too late because we really should have been doing this stuff for a long time. And I guess when you start doing these things, you start seeing the saves and the people that really a few years ago would not be alive that you get to shake their hands. It's really very rewarding. And so in 2019, we had the opportunity to go to Resuscitation Academy. It was actually Carrollton Fire and some other folks that sent me, and it was one, just like going to any other conference, you're kind of skeptical about what it's going to be like. And as soon as I got there and started hearing from some of these individuals, we really realized that we were focusing on the wrong things, and we should be focusing on staying on scene. We should be focusing on high quality compressions. should be focusing on defibrillation and really the entire chain of survivability. And that really starts way before we get there on the ambulance, certainly way before this patient comes to the emergency department. But someone recognizing the cardiac arrest, our telecommunicators who are such a vital part of this, having a citizen that feels comfortable delivering hands-only CPR to these patients, and then getting the 911 system going, have AEDs available, having our police departments and other first responders and city workers having AEDs and really not afraid to get on someone's chest and help out. And then all the way to EMS. When EMS get there, we really have to be great stewards of high performance CPR. And high performance CPR is not just doing a few compressions and then focusing on airway and everything else. It's really getting on the chest, staying on the chest, and trying not to be off the chest for any more than 10 seconds at a time. So our hardest part was coming back to the state of Texas, where we have probably at our agencies 95% paramedics, and then really trying to implement these things, with Lucas devices and with advanced airway skills and with medications, and really put this all together. And so when we came back, we tried to do that. And I like to say we had a lot of great education, we had a lot of skill, and we had a lot of great leadership, but I think we also had a lot of great luck. And everything kind of came together for us across really all of our systems. And we had our telecommunicators really jump on board, our law enforcement entities, a lot of our cities bought AEDs for a lot of the city workers, and really kind of set something up much like Seattle runs. And then we started getting saves, and we started getting lots of saves, and we started getting so many saves that I had a hard time posting the saves on our social media because they happened all the time. And really, we got to the point within a few years that if we didn't get somebody back from cardiac arrest, our crews were fairly disappointed. And so we had the opportunity to go back to the Resuscitation Academy a couple years later, and they wanted us to kind of tell our Texas story. And they were quite pleased with our numbers. And actually, a big piece, too, was getting on the CARES registry. We brought that back to our regional RAC and really pushed agencies to get on board, because we really had no clue what our data looked like at all. And in addition, our crews had no idea about, really what a well-run cardiac arrest looked like. So we started giving code stat data back to them and showing them their time on the chest, showing them their pauses. And so we went back to the Resuscitation Academy and presented. We were shocked about how far we had really gotten in a couple of years, and there were a lot of key things that happened during those 2 years. But here we are 6 years later, and we've implemented it really across all of our best EMS agencies. PCHD came on board about 3 years ago, and Jeff can tell you more about kind of how we got that going here. But we're now proud that we actually we've become a lighthouse community through Resuscitation Academy. You can go on their website and you can learn about that. There's states that are lighthouse communities. There's I think we're the only med control entity within best EMS that is. Several cities, Hilton Head and King County area in Seattle. There's some great cities and states involved throughout the country, but really our mission now is to just spread the word. And so we had one down in Lake Jackson, down in the Houston area, and your folks were able to come. And really, I think the important thing is this stuff doesn't cost a lot of money. There's a lot of low-hanging fruit that we can change right now without a lot of cost, without a lot of extra equipment, and that's kind of what we've done. So let's kind of get started. I think Skipper can probably tell you a little bit more about what he's learned since coming on board, and then Jeff can kind of tell you a little bit more about implementation from his agency standpoint.
Yeah, just taking off where Dr. Northeim was talking about, the beautiful thing about this Resuscitation Academy is that it's free to attend, right? There's no cost to attendees besides your hotel costs if you're staying overnight, but it's all provided free of charge. And I can remember back when I was in residency back in 98 to 2001, even back then we knew about Seattle and King County having these phenomenal resuscitation rates. And the error back then was that we just thought they were doing what we were doing and just doing it better. But no one at that point really asked, well, are they doing something different there? Why are they getting such great resuscitation rates? And it wasn't until I came on board with Best EMS and heard about going to the RA from Justin, and then it all made sense, right? Well, why didn't, like you just said, why didn't we do this 20 years ago when we could have gone over? And that's kind of why they started the RA, because I believe they started having agencies go over and want to learn about their process. And so they just wanted to formalize something to really improve cardiac care, throughout the world. Because their view is that if you have a cardiac arrest in Montgomery County or Parker County or Wichita, Kansas, your chances of resuscitation should be the same as if you have it in Seattle, Washington. And so that's what we're striving for.
When it came to implementation, when Best EMS came on, we kind of did several different things. We had some classes in person up here at our training center in Weatherford. We brought fire departments in, we brought our crews in, and we went through kind of the whole HPCPR thing. Obviously, maximizing hands on chest, decreasing delays, teaching our crews to make sure that they were only taking in the equipment necessary to start resuscitation, and we weren't loading up the stretcher as kind of we used to do, which we found can cause some pretty serious delays in actually getting on the chest. After our initial classes, we used our Tahoes, our supervisors, to go around the county teaching. We've used our FTOs to continue training our crews, and we've also implemented, including the field crews, driving around, going to fire stations, and just continuing the HPCPR training. That way, we're not getting stagnant. We're not losing our skills or getting rusty. So we are constantly going around the county and just practicing throwing the Lucas, getting on the chest quickly, rhythm recognition, everything like that. And we have seen a massive improvement in just buy-in from our crews, from fire department, even, and of course, since we've been getting more saves, we've also seen a lot more excitement or involvement from the community. And it's been awesome. It's been a lot of work, but it's been worth it.
Excellent. Well, we took some take-home points from our attendance to the Resuscitation Academy from the MCHD side, and some of these I just wanted to hit on really quickly because they're changes that we made based on this session, and that's exactly why you go to meetings and to training, is to bring back ideas and ways to make your service better, to make patient outcomes better. And so one of the things that was mentioned early on that Justin mentioned was that this starts well before our EMS crew arrives. And we say that a lot, but I believe it continues to get underappreciated. And that is, how quickly can we get bystander CPR in place? How well can we train our community? And how solid is our telecommunicator assisted CPR? And those things are absolutely positively vital. One of the things that we realized was that all of our dispatch tones were the same throughout the county. And that in and of itself seemed like such an easy and straightforward and dumb moment for all of us, is that why don't our cardiac arrest dispatch determinants tone out differently? And so that was probably the first thing that we attacked. Was that's pretty easy. There's nothing expensive. There's nothing fancy. There's no equipment. Just let people know when it's a big bad one. And that gets everybody's mind in the right place. That gets everybody's sense of urgency turned in the proper direction. And just seemed like really one that, to Skipper's point, we should have been doing 20 years ago. So have y'all had feedback on alarm tones? Is that something that you did from the beginning, or was this something that y'all drew from the Resuscitation Academy? It was a real duh one for us. Like, yes, let's change that tomorrow or as soon as we can. Give me some thoughts on that.
Yeah, no, we started in several agencies before we had come out to PCHD. We do it here as well. We do have a pre-alert tone here for every call, basically as soon as the address gets inputted. So I wouldn't say that it makes as much of a difference out here with the pre-alert tone, because usually once the pre-alert tone goes for your truck number, you're already getting in the truck, wrapping up whatever you're doing and getting in. We did just complete a study with UNT Health Sciences and our research side on tones, and it definitely does improve your overall shoot times. I think it is very, very, very impactful on agencies who do not do pre-alert tones. So basically they're waiting for address, nature of the call, and priority, because we do priority dispatching here with 3 different levels. I definitely hear in a lot of the other cities that we have, as soon as you hear that tone, you're not getting a pre-alert, people definitely get out of the station, get in the truck a lot quicker, and their whole, the mental picture changes for them, because you hear the automated tones all day long. And when you hear the different tone, it's much like the structure fire tone of fire department. You've seen, the firemen jump in the fire truck with the structure fire tone. I mean, they're moving out. So yes, I definitely think, and that's something that we have implemented here, we have kept here, But I don't think it has as much of a play here just because we get the pre-alert and people are already heading to the truck and getting in the truck and starting towards the address. But it is definitely something that I think impacts our just getting us on mentally, just getting into the call and then, really trying to get there a little quicker.
Perfect. Let's move into the Lucas. You mentioned Lucas and mechanical CPR devices. These are part of our world here in Montgomery County. I don't want to delve into mechanical versus manual CPR arguments. They're a part of our system, and we believe from a cognitive offloading standpoint and a medic safety standpoint that they're going to stay as part of our system. But anytime we're going to introduce a pause, whether that's changing the person who's doing compressions or changing from a person to the mechanical device, that's that 10-second limit that we can't go over, or we lose our filling pressure. And there's plenty of infographics and pictures and ways to convey that message out there online. You see those in almost every cardiac arrest lecture. But we have to put the Lucas on, and it has to be within one of those pauses. And this is one in our system that anytime we have drift, we can see when we're looking at our cardiac arrest data. If you see a prolonged pause, you can almost guarantee and look at our CAD notes and our data, and that's usually when the Lucas arrives. We don't have a Lucas device on every truck here in the county, so oftentimes we can pinpoint it to, oh, that's when the Lucas got there. That's when the pause showed up. So when y'all take this and tell the listeners some of the really simple but ingenious ways that you've taught your crews to put the Lucas on quickly and to be prepared and proactive as opposed to reactive.
So the big thing with the Lucas is that it takes practice and practice and more practice to get really good at it and really efficient at it. And it's one of those things that it's one of those skills that does decay over time if it's not practiced. And so there's a couple of ways that different ways that some of our agencies deploy it, but some of our better agencies at deploying can get it in under 6-7 seconds. And so they make it kind of like a competition between crews, right? Who can get it on the quickest. And so we certainly teach that when they arrive at the patient and they're starting manual compressions, just go ahead and raise the arms above the patient's head, get those out of the way. We're going to continue manual compressions until everyone is adequately and feels really good about deploying the Lucas. And that may not be until, 8 or 10 rounds of CPR that have occurred. They generally deploy it then with kind of the clamshell method with one side attached already, and the airway person about 15 seconds before their rhythm check pause will go ahead and drop their airway device, stand up and grab the patient's wrist and be ready to lift the patient up to assist placement. Then they'll place it under, clamp it down, get the puck in place, and make sure it's in the right location, and then start it. And then another good thing that we've learned is going ahead and put a circle around the puck so that we can catch any drift that occurs, because we've all seen patients come into our ER, right? And during movement of the patient to the stretcher, or then from their stretcher to our bed in the ER, the device can have significant drift. So anything else you want to add?
No, I think the important thing is there's really never been a study showing increased survivability with the Lucas. And I think one thing that, I think Seattle is starting to use a little bit of Lucas, but I think the moral of their story is we just want to be really good at manual compressions because that's the only thing we do. I think that if you have a Lucas device, it's great. It's great for transport. Obviously, depending on staffing models, it's very useful. We're all happy when it gets on and it gets placed on correctly in a timely fashion. But we only put it on at the 2-minute rhythm check. We have to do it within 10 seconds. And then if it drifts, if it starts, compressing over the xiphoid, it's not going to be useful, right? If it starts to, become over the aorta, it's going to affect the outflow track. And so you can get a little more aggressive and do ultrasound and see if it's affecting the outflow and stuff like that. But you got to use your hand straps. You got to use your neck straps. You got to circle it. And the other thing is we have to be good at manual no matter what. I mean, if you have, somebody that's too small, a pediatric patient, we can't put a Lucas on if they're too small. If you have an obese patient, we can't do it. We've had some 25, 26-year-old, methamphetamine addicts who are too small to put the Lucas on. So I think if you're going to use it, and we do, and all of our agencies have them, and that was one of my biggest issues coming back from the RA, is I had to kind of figure out how we were going to use it effectively and place it quickly. And really my agencies and all of our agencies really challenged us on that because they didn't want to get rid of it. And so they challenged us over and over about how quickly they can do it and to prove that they can do it. And if you're following your code stat data and sending these back to the crews, you'll see right away if there was more than a 10-second pause. So I think there's multiple factors with that. I just think that you have to understand that it doesn't change survivability. It does not increase survivability. And I think Tom Boothole he's with the RA now. He's with Hilton Head Fire initially. He showed his survivability go down and trained and finally found some ways to make it more efficient. But we got to keep that in mind.
It's a great lesson for shiny toys and EMS. If shiny toys distract us from our foundations, they can be worse than neutral. They can be harmful. And so we have really hammered home those same points that, number one, you have to be good at manual CPR, period, the end, because sometimes that's all we've got. How we deploy that Lucas is key because that affects our pause time. It's just like any other pause time. You don't get a special carve out for putting on the Lucas device. If you're off chest for too long, your chance of neurointact survival drops. There's just no way around it. You mentioned the Lucas migration or Lucas walk. That's a subject that lots of folks have sort of hit on and realized over time, is that when you look at that CPR compression data and you see it dipping, oftentimes that correlates with the Lucas actually anatomically dipping on the patient. And this is not rocket science. If you're compressing the liver, your cerebral blood flow is going to be trash. If you're over the aorta, then you start to affect the LVOT, like you mentioned, and there may be some future roles there for imaging. But in the end, we want the puck to be on in the right place when we start, and we want to make sure that it stays there. So really simple way to prevent that is to just make a circle with a marker. And that is not an expensive or intensive prevention method. That's easy to teach. You can take that out to your crews in the field and do that really, really quickly. So that's what I love about the clamshell application. Why put it on in 2 clicks? Have one side clicked in already, slide it under, and then you've got 1 click. It takes a step out. And anything that you can do to make this more efficient as far as Lucas placement or Lucas accuracy is going to improve survival relative to long pauses or inappropriate anatomic spots for compression. You mentioned CARES data and the CARES data registry. We're CARES participants here at MCHD. For the listeners out there who don't know what CARES is, let's fill them in on CARES and why it matters. I believe this is a really important piece to hit on because you can't get buy-in. I don't believe you can't get enthusiasm, just like anyone in any job anywhere. If you don't know that what you do matters and makes a difference, how enthusiastic can you possibly be? And that's where CARES comes in for us, is really a measuring stick and a way for our medics, to know how we're doing relative to year to year, relative to each other, and also relative to the nation. So how long have y'all been involved in CARES? Give the listeners a little overview of CARES and why it's something worth participating in and championing.
Well, when I came back from the RA, this is one of those, it wasn't the lowest hanging fruit because obviously there's a cost to it, but it was one of the fruits that we felt after getting our metronomes and compression rates right, our time on the chest and our code stats and all that stuff. We felt like it was something to tackle. And like I said, we had a lot of great leadership within our local RAC, and it was something that many people have been thinking about for a long time. And I brought it back and I kind of championed it here with our local NIC track and really said, hey, we need to kind of resurrect this. We need to figure out a way. And luckily we found funding within our RAC. So it was free for those who wanted to get involved. And regionally, we started filling in the gaps. I mean, really, there was only a couple agencies around our area using it. And if you don't know what your data looks like, you have no idea what you need to change. And I think that was the biggest take home I learned at the Resuscitation Academy. And they were heavy into data, overall survivability, their Epstein scores, all that sort of stuff. We had no clue. And the reason we had no clue is because we could track our ROSC rates, but at the end of the day, once we drop them off in the ER, we could tell whether or not they, survived to be dropped off in the ER. Maybe if they made it, at least maybe out of the ER, we would know, but we would have no idea of their chance of making it out of the hospital. We'd have no idea, what their neurologic CPC scores were and what their outcome was. And so it took a lot of work. It took a lot of great leadership, but we just started inputting data. Our RAC paid for it. It's changed now. We can use our RAC funding towards it, but the agencies do have to pay for it. And it depends on size. But we really kind of spread it throughout the Metroplex up here. And so now, it's very neat to see, our high performers. It's very neat to compare to, Seattle's numbers and really kind of see where we're at. And we're very close to them. And we have some agencies that actually are higher than them. So that's actually really rewarding too. But it's something great to take back to your board, to take to your council, your mayor. I think that, probably in the next 5 to 10 years, it should be something that, cities and regions should be able to, you should be able to find it on their website. Hey, what is your Epstein score for your response area for your city? It's an important piece. The fire service does a lot with ISO ratings and stuff like that, but it may make a difference. Say, I may want to live in this town because they have a high overall survivability and their Epstein score is high. So we have continued to support it, and I hope that if you're hearing this today and don't have it, that you'll at least look into it, push your RAC, push your region. The overall cost to your system is actually very low compared to the impact it will make on following your data and showing, hopefully, a line of improvement over the next few years for you.
And I'll tell you what.
Nuts and bolts, what you do
Casey,
is go ahead.
Oh, it's really something that you kind of take for granted when your agency is participating. And then if you have one of your agencies that does not participate, you really notice immediately. All of a sudden, you don't have access to that data, and you can't really compare yourself to yourself or anyone else. And so it's really one of those things that's missed when agencies don't participate.
So nuts and bolts, what actually happens is our folks here on the quality clinical side here at MCHD take our cardiac arrest information, de-identify that, enter it in the CARES database, and the folks on the CARES side collect the hospital outcomes. And basically those two are intermeshed, and that is the holy grail of EMS feedback. It's actually knowing what happens with hospital outcomes. Because to your point, Justin, we take so many patients into the ED, we change over care, we clean off our straps and stretchers, we grab an energy drink, and we roll back out for the next call, and maybe peek back in the room to see if we've got sustained ROS or a central line or a new airway or whatever it may be. But we rarely in the past know what happens to these patients, and that's in the individual. For the administrators, the medical directors, the EMS chiefs out there, for the public, what does your system look like in aggregate? And to know, hey, here's our ROS rate, here's our neuro-intact survival rate, and connecting the dot between EMS to the hospital, to the ICU, to discharge. It's just an amazing, powerful piece of data, and that's something the medics can hold on to in their individual cases and where they work as a whole. And then you can compare it to yourself, you compare to others, and you can turn it into a healthy competition to try to improve patient outcomes. And that's the end goal. So I would encourage anyone who's not involved in CARES to look into it, to look into funding sources. There is a cost. It is not an exorbitant cost for what you get on the back end, and that is knowledge as to how many people are out there walking around because of the good work that our folks are doing out there in the field. So where do y'all see, and I'll let one of you take this, where do you see the Resuscitation Academy going in the future? And for those of you all who are interested and are like, hey, this Resuscitation Academy thing sounds great, we will definitely post links and QR codes and all the necessary information for you to find out about the Resuscitation Academy here in Texas and those opportunities, and also nationwide. So if you're interested, we'll hook you up in the show notes. But closing up today, going up to the end of our time, where's this going in the future? What are a couple things that in 2030 we're going to see in cardiac arrest as standard of care that we'll be looking back on 2025 saying, yep, we called it? Give me a couple.
Well, I think one of the things that we're going to have to do with the Resuscitation Academy is we've made great strides through it within EMS. But as you know, things are slower to take a hold in the hospital setting. And I think we're going to have to take a lot of what we've learned back into our hospitals, back into our emergency departments. And it's the simple things that we all concentrate on now, right? The time on the chest, deploying the Lucas device. I can tell you in my emergency department, there's only about 2 people that I really want deploying the Lucas, because if it's left to most, it's going to be a 30-second ordeal to try and get a Lucas deployed. So I think that's where we as EMS leaders will have to go and maybe get some of our, supervisors and medics to actually step into the hospital and assist with some of the education to our emergency department nurses and staff to advance the care there, because it's frustrating, right? If we take great care of patients in the field and then we bring them to the hospital and we see the long pauses and we see the complete time off the chest, and we're kind of like, wow, everything we've been trying to do for the last 30 minutes with this patient is now not being continued. So that's one area I think that DARI and us as EMS leaders will have to pursue.
I think one of the big focuses, like Skipper said, would be in the emergency department, but in addition, floor codes. I mean, we don't go to a lot of floor codes anymore because we're at a trauma center, but I would imagine that there's a probably a pretty big learning curve on the floors. We have really tried hard with our staff and the EDs and respiratory therapists and our nurses and techs to really try to make sure that we are being good stewards of all of the Resuscitation Academy low-hanging fruit. So our agencies that come to us really can see that we're practicing the same thing. But I think focusing on other physicians, nurses, floor nurses, ICU, I think is really a major thought. And, maybe when we come down there, you come up here, I think another big thought is we do a lot of CPR checklists that we have laminated cards in the side pocket of our monitors, which the Resuscitation Academy kind of gave us the idea. But when you think about pilots, they fly many, many thousands of flights and they still do checklists. And I think for us to have reminders of, hey, ooh, I forgot to hook the oxygen up. Ooh, I forgot capnography. Ooh, I forgot to turn the metronome on, right? It's nice to have reminders on a checklist. And then our termination criteria is on our checklist. And then we went as far now, which is a totally different topic that we can certainly spend another hour on, would be how do we handle our traumatic arrests, really? And the literature is really pointing towards not going with ACLS drugs, not going with compressions, working on your skills. And so we do finger thoracostomies and needle decompressions and pericardial centesis and ultrasound and focus on airway. So that's also on our checklist as well. But I remember somebody telling me at one point that they had kind of a study at shock trauma on floor codes, going back to that. And on average, the respiratory therapists were bagging upwards of 70 times a minute on floor codes. And so when you look at some of the PIG stuff that we show and research that Dr. Idris and a lot of way smarter people than me did back in the day during the ROC trial and a lot of the AHA stuff, I mean, our goal should be 10 breaths per minute. And we do 10 breaths per minute. And we do, lower tidal volumes and lack of PEEP for the reason of we know that those pigs did better, right? And so if you could imagine 70 times a minute, the survivability is almost zero when you look at kind of, exponentially looking at the chart that they showed, at least in the pig research. So I think those are some things that we really need to focus on. And epinephrine talk will go on and we'll continue to talk about that. But we personally stop at 3 epis. I see very few people surviving after 3 epinephrine.
If you want to listen to Epi Talk, I'll guide everyone to the EMS Lighthouse podcast and Dr. Jarvis, who speaks more eloquently and more informed than I ever could about the swamp pit that is epi and its role in cardiac arrest. But I hadn't, honestly, when I wrote that question, I didn't know how y'all were going to answer it. And the hospital floor codes is a really powerful one, because this is something that we absolutely, positively, hands down outperform the ED in the hospital. And that's high performance, good pit crew CPR. And anybody that's listening out there that wants to argue with that one, let's do that, because I think we can win that one pretty easily. Yeah. I also feel like that you mentioned ultrasound earlier. If I had to predict, I believe that at some point the technology, size, cost, picture quality is going to allow us to look at the left ventricular outflow tract during arrest and guide our compression placement more accurately, whether that's 5 years, 10 years, or 15 years down the line. I believe at some point before I'm done doing this, we'll have eyes on the outflow, and that really is the key, is perfusing the coronary arteries and perfusing the brain. I think it's kind of a no-brainer. So I believe that one's gonna come to fruition. Traumatic arrest, we could go for hours. That's not one for today. We'll say that for the next episode, whether or not we ever get to a non-invasive way to actually measure perfusion pressures and diastolic pressures and guide our resuscitation that way, or arterial lines. If you're a believer in that, I know some folks out there are trying that both in the field and in the ED more and more. That's a hot topic. We'll see. But for now, those low hanging fruits that y'all mentioned, time off chest, got to be minimized. Lucas walk has to be minimized. We have to know our outcomes to know how we're doing, and so our crews have buy-ins. It's really a pit crew approach that's not just on scene, but it's a community pit crew approach, from bystander CPR to telecommunicator assisted CPR to our fire partners, our EMS partners, and then into the hospital, ED, floor, ICU, out back into life. Hopefully that's the goal. So thank y'all, each of you, for joining us today. We're up against time. As always, if you're interested in what we talked about today, check the show notes. We'll have links to all of the Resuscitation Academy stuff that you'll need to find out about it, get involved, sign up, go. Your service will be better for it. Your patient outcomes will be better. If you have questions or concerns, please email us, podcast@mchd-tx.org. Leave us a like, leave us a review. More importantly, follow us wherever you listen or watch. We'd love to hear your feedback. We love to make new episodes based on your feedback. Thank you, Jeff. Thank you, Skipper. Thank you, Justin, for joining us today. Appreciate your time. You're doing great work up in Parker County. Keep it up. As always, for the listeners out there, thank you for joining us. We'll be back with another episode soon.
This podcast was brought to you by the Montgomery County Hospital District, Texas. Production and editing by Andrew Adams. Questions or comments, which are always welcome, can be sent to podcast@mchd-tx.org. Make sure to subscribe above to keep updated to all our future casts. Music, copyright, Kevin MacLeod, Incompetech.com, licensed under Creative Commons by Attribution 3.0.